Hi everyone, welcome and thank you so much for joining us. This is going to be the last teacher seminar for this school year before the summer holiday. And we've got a very interesting topic today. Just to introduce our speakers. So today we have from the Royal London Children's Hospital, we have Dr. Birgit Westphal, who's a consultant child and adolescent psychiatrist, and Dr. Elizabeth Nash, who's a consultant clinical psychologist. And they're going to discuss addressing the psychological needs of school children with persistent physical symptoms.
Just to introduce ourselves, obviously, as Julie just said, I'm Elizabeth, and myself and Birgit co-lead the paediatric liaison team, which is based at the Royal London Children's Hospital. So we're a multidisciplinary team, so we're co-led by psychology and psychiatry, but we also have mental health nurse and other psychologists, psychotherapists as part of our team at the Royal London. And we specifically work within the hospital with young people and children who present with physical health symptoms. So we support young people with a whole range of physical health symptoms, and they might be in the hospital as inpatients, but we also work with them as outpatients, and we do lots of liaison with local services and schools.
Yeah, thanks, Elizabeth. So we wanted to just quickly talk about the body and mind concept, where there is a false dichotomy separating mind from the body, and that is sort of in everyday language and society we do it. And even our health system is set up like this. We have mental health trusts and we have physical health trusts, or they're also called acute health trusts. So it's really important to unify this. And I think our service is quite unique in the sense that we are co-located and integrated into the pediatric acute trust, into the children's hospital, and work as a psychological mental health service within that medical service. And that's really important. So the next slide, please. When we think about people, we need to consider that the mind is in the body and it is well connected, and we cannot sort of separate it out, like saying, okay, we treat your broken leg and your diabetes, but if you have any problems with this or you're agitated, then you have to go to a separate service. It's good to do it together, and that's what we do.
So just thinking briefly about how our minds and bodies can affect each other, and I think we can all think about this in terms of our own experience. We know that anxiety often has real physical symptoms that go along with it. So you might have young people who are coming up to exam period and they start to experience gastro symptoms, and that could just be butterflies in their tummy, but it could be needing the toilet more often or having stomach aches. So things like having nausea or shaking. So we know there's all sorts of physical manifestations of our emotions, and often of when we're feeling worried. And again, the kind of physical symptoms can often lead to more emotional impact. So young people who are struggling with ongoing kind of chronic pain or ongoing chronic health problems, that this can impact them in terms of their mood, and they might manifest with sort of low mood or have significant anxiety or worries about these physical symptoms. So I guess it's really, again, thinking about how our bodies and minds are completely interlinked, and physical symptoms can impact our emotions and our mental health, but at the same time, our mental health and our emotions can constantly impact our kind of physical self and our body.
So the question is, what is PPS? Next slide. And we want to just point out that different subspecialties, different doctors in the hospital and school and society, we have all different names for it. Persistent physical symptoms is a term we settled on because patients like it and it just describes what's actually happening. But it is often referred to as MUS, medically unexplained symptoms, or lots of others. Next slide, please. The terminology, depending on which team sees someone and what the symptoms are, neurologists see young people with non-epileptic seizures or loss of the use of a limb or an organ being suddenly mute, not being able to see, blindness, deafness. That's usually seen by neurology, and they call it functional neurological disorder or non-epileptic seizures. If a child is as a result very fatigued, there are chronic fatigue services, and they call it that. There is a new, there are patient representative groups, and they're parliamentary representative groups, and they're quite active, and they have complained about some terminology. Following those complaints, DSM-5, or our system that gives names or diagnosis, has changed from MUS or psychosomatic disorder to bodily distress disorder. I'm not quite sure if this is a very helpful term, but that's definitely used in the DSM-5. We can still describe it as psychosomatic disorders, and sometimes it's a complex regional pain syndrome. So you may get young people with a letter from the hospital with any of these, but it's all what we call PPS, persistent physical symptoms. The core commonality is, though, that any of those presentations cannot be treated with medical treatments, with conventional medical treatments. I think that's what we all find is a commonality in all of them. Next slide, please. So I'm just going to come up with some very full slides. The next one, please. So please forgive me for this. I don't know if you sort of attack your pupils with slides like this. It's not very, it's very full, but it's very simple. It is just showing our autonomous nervous system, and it is what everybody's familiar with. It is that we have the very simple reactions that we are not able to control. It's fight, flight. If we're anxious, we're either running or we are freezing and have all these things happening to us, sweating, our pupils dilate, we get red, hot, flushed, our heart rate goes up, we feel like having diarrhea or vomiting. And these are all symptoms, a sign of distress or anxiety, exam anxiety, situational anxiety in a social setting. And this is all very normal. We all have it, and some people have it more or less. And it is a bit of a matter how we are able to control this. And it can go into a vicious circle. That's what Elizabeth has explained in her earlier slide. Next, please. And that's over to Elizabeth, how it may present.
So, as Birgit mentioned before, we know that young people present with lots of different types of physical symptoms. So there's not a kind of consistent physical symptom that we see young people presenting with. So we have some young people who come into the hospital because they're experiencing seizures or loss of function of a limb. We fairly often have young people who seem to stop being able to walk, and they might experience weakness or pain, significant pain in their limbs, things like tremors. And because of the different symptoms, they may come in under different routes, so possibly via neurology or via orthopedics, because they're having difficulties with walking and they're having investigations to see if there's problems with their bones and their muscles. We also know there's lots of young people who suffer from gastro symptoms, so stomach pains and constipation, or they have the more general symptoms that might come under lots of different specialities like fatigue and chronic pain. And for often a lot of these young people, that they might be having multiple tests to try and understand why they're experiencing these symptoms, but might be finding that a lot of the tests are coming back clear, and this can feel incredibly confusing for the families and also for the professionals around them. And what's, I guess, one of the really key bits and that we want to get across today, and that's so important to how we work, is that we acknowledge and validate the symptoms that they're experiencing. So we know that even though there may be no clear medical explanation for why these young people are experiencing these symptoms, that we treat them as very real, because they are very real symptoms, even if we might not completely understand the cause, and they have a significant impact on them. So just thinking about the impact, if we go on to the next one, I guess these symptoms impact all areas of young people's lives. So as we mentioned before, there can be a sort of mental health impact. So the sort of anxiety about what's wrong with me, why am I experiencing this, what might be happening. and low mood, about just generally feeling quite fed up, about being in pain or not being able to do things. Has a huge impact on family, both in terms of family life and being able to do normal activities like going out for a day trip or doing things together. Obviously, a huge level of anxiety often for parents around what might be wrong with their child and why that's happening. Definitely, and I guess partly why we're here to talk today is that it has a huge impact on school. A lot of the young people that we're seeing have either stopped going to school completely or have very sporadic attendance, and that's causing lots of difficulties in their life. And then also on friendship, so partly friends not really understanding why young people can't do things with them, but also that if you're missing school, you're missing out on those key events in your friendships, and then having to come back in and try and slot back in with peers again. And obviously things like hobbies and sports, and just being able to do generally the things that young people enjoy doing. And then going on to thinking about the impact on the family, because I think that's such a key part of the work and how we try and intervene. So we know this is a really highly stressful situation for families, because often, you know, a parent's role is to try and find out what's wrong with their child and then get them the right treatment and make them better. And what can be so difficult for parents is that the message that they're sometimes getting from health professionals is, we don't really know what's wrong with your child, or we do understand what might be going on. You know, we see other children this, but there is no quick fix. There's no kind of medicine or treatment that's going to make this better. And often parents are finding that there's quite a lot of pressure coming from outside the family as well. So sometimes family members who are suggesting, well, do you need to take them to another hospital or another specialist, or, if you know, doing lots of internet research about what might be wrong. So there's lots of uncertainty, I think, and worry for families. And then again, often we find that there can be a level of conflict between families and schools, because I think for schools it can be quite obviously, there's important things that schools have to do in terms of accounting for attendance, and children don't necessarily have a very clear diagnosis, or there's not necessarily one medical professional that schools can coordinate with to try and understand what was happening and to try and support this young person. So it has, a huge impact on the entire family. And yes, thinking specifically about school and the impact there. Next one. So I think what we often find is there kind of is a bit of a vicious cycle for young people. So they present with some symptoms, and that might be a kind of chronic pain or fatigue, and they start missing some school. They then stop seeing friends as much, and start to find that those peer relationships are becoming a bit more difficult. They then often are missing work at school, which sort of increases their level of anxiety and low mood, because they're kind of worrying about, I missed that lesson yesterday, I don't quite know where I am in the lesson today, and that they start to kind of get a build-up of stress and worry, and that often I think the physical symptoms then worsen because of the kind of increased stress, and that leads to more absence from school, and you get this kind of vicious cycle where gradually I think young people are missing more and more school, and things just build up, and it can be quite tricky to know how to intervene. So I guess just thinking about kind of the physical symptoms as the tip of the iceberg. So that's what we're seeing. You know, we're maybe seeing a young person who's limping or is using a crutch, or is having these seizures. But what is often less obvious is what's kind of underlying those symptoms. And we know that we very rarely come to one solution where we go, oh, that's the thing that's been causing it for this young person. But we know that there's often multiple factors going on for young people that we see. And there are kind of common themes, I think, that come up. So sometimes we find that there's been a significant stresses in the family, that there may have been previous trauma or kind of recent events that have increased kind of the stress and resilience, I guess, of the family. We know that sometimes these are young people who possibly may have neurodiversity or learning needs that have not necessarily been that obvious or kind of identified, and are therefore finding particular transitions hard. So the transition to secondary school, or as social relationships become more complex at school, that sort of more starts to manifest as these physical difficulties. Quite a lot of the young people that we work with find it quite hard to verbalise their thoughts and worries. And I guess one of the hypotheses would be that things manifest more physically because they find that so difficult to kind of identify their own emotions and be able to talk about that. And sometimes, I guess, and I think it's really important that we don't make kind of generalizations about all these young people, but we know that some young people have quite significant perfectionism and therefore may find it quite difficult once they start missing some school and they're not able to function at the level that they've been used to. So just to think a bit about how we approach and work with young people. So one of the main things, I guess, from a medical point of view, and I'm just aware we're not representing them. We don't have a kind of consultant paediatrician here at the moment, but one of the key things that the medical teams try to do is to kind of complete any investigations promptly. So I guess that families can be reassured that there has been thorough investigation and any kind of significant medical conditions have been ruled out. Because I think, the concern for families is often, does my child have a really serious condition, often something like cancer, and that they're worried that there might have been something that have been missed. So it's really important that paediatricians act quite quickly and can reassure families that they have thoroughly investigated, but also that we don't continue doing lots of investigations, because we know that that's very stressful for young people and can in itself cause kind of continuing trauma. Really trying to build trust and rapport with young people. We know that they've often seen multiple medical professionals, and sometimes they may have felt that they have had messages that kind of suggest that the symptoms aren't that real, or they're in their head. I think that's a phrase that's used a lot by families, that they sometimes pick up. And so I guess it's really we want to really build that trust and rapport with the young person family to say, we completely believe your symptoms, we recognise the impact it's having on your life, and also that we have some confidence that we know how to intervene. And it's not, even though there might not be a medicine or a medical treatment, we do know that we can intervene and that things can improve, and kind of helping to hold that hope for them. We know that all the evidence says that we should really be working from an MDT position. So just often having a purely physical intervention doesn't really work very well, which is partly why we have mental health professionals within the hospital. But we also know sometimes if young people just go to like a CAM service where there isn't the physical health representation, that doesn't always work that well either. So it's so important that we work as part of a multidisciplinary team, with physios, with OTs, with the paediatrician, and that we work alongside each other so that we're giving really consistent messages to families as well. Because also what kind of creates doubt and impacts that rapport is if families feel they're getting different messages from different professionals. So possibly some people saying, no, you need to have further investigations, while other people are saying, no, we've investigated far enough. We know that early intervention is really important. So the longer these symptoms go on, the harder it gets to intervene and to kind of see improvement. We need to work with the whole family system, not just the young person, and the wider system as well. So really important that we're working with schools, and not just with the young person and their family. And that the focus that we really try and make is to look at function and rehab rather than symptom reduction. So I think if we continue to focus very closely on, for instance, a young person's pain, it's almost like if you have a toothache or something and you kind of sit there thinking about it and worrying about it, the pain gets worse and worse. Whereas if you go off and do something else and possibly are quite absorbed in something and your focus is taken off that pain, you actually stop experiencing it for a while. So we tend to try and focus with young people about what do they want to get back to doing, get back to school, get back to doing things again, but that we might not be able to immediately reduce their symptoms, and we can't wait for the symptoms to reduce before we start doing things again, and that's really key. And that we give sufficient time, so we don't expect young people to go from not going to school to being back in school full time within 2 weeks. We kind of take things at their pace, and we focus on progress rather than having very set time goals for things.
What I wanted to quickly say is it's a repetition, just in a different table. What we need to consider, there is not this kind of magic assessment we need to do to come to the bottom of it. What we need to do, and however we do it, we need to see what factors are going on for this young person in their life. And there are predisposing factors. We need to see why did it start at that point in time, what may have triggered it, and what perpetuates it. And this could be family, it could be anxiety, it could be social factors, undiagnosed learning difficulties. And then there are also positive prognostic factors that can make a big difference, and we need to lean on that. And with my young person, he had an incredible family support. That was great, and good friendships. Next slide. And this, if you tick one more, there is this thing flying in from the bottom. Yeah, sorry, I don't know why I have this effect. So this is just yet another slide showing that there are so many factors contributing to this. I think with these presentations, we're looking for similarities and what is common with all of these kids. But I think it's best, not kids, young people, it's best to really have an open mind. That's really important. All need to come together. School, MDT, like Elizabeth said, it is an MDT approach. We need to have an open mind and really explore all areas of this young person. And we have been often surprised, haven't we, Elizabeth, that something we did not really expect has come to light, and we then worked on that, and it was something completely unexpected and made things better and a real difference. That's it. And now over to you, Elizabeth.
So I was just going to touch on a couple more things in terms of, I guess, how we commonly work with young people and approach. So the kind of boom and bust that I touched on earlier. And I think this is just such a common pattern that we see young people get into, where they have a good day with their symptoms and they've maybe got a bit more energy, a bit less pain, feeling a bit better. So they really push it, whether that's they go to school for a full day, or they have a whole day out with their family, or they just stay on the trampoline for a couple of hours. It could be all sorts of things, but then feel that, there's that great feeling of, yeah, I'm back to normal, things are better, but then find that either later that day or the next day, they're completely wiped out. And sometimes they then have a real spike in their symptoms. And often that's really disappointing, and they end up withdrawing and kind of in bed for a few days or just not doing anything, and then get back into this cycle again of a good day. And I think sometimes this is a kind of family cycle where they have a good day. So sort of parents push them a little bit or family push them a little bit. And sometimes it's more driven by the young person themselves. So we really think about this with young people and explain this to them and kind of look at this boom and bust cycle, and think about how it's very difficult to recover if you're in this pattern constantly. And instead we want recovery to look more like that. What we want to take instead is a kind of pacing approach, so that we find a level of activity that they can tolerate and they can do consistently day in, day out. So that might literally be, for some young people, 1 hour at school. And for other young people, it might be a bit more. But the important bit is that they can manage that consistently for a while. And once they're managing that consistently without any negative effect, they then think about increasing their activity a bit more. And therefore that recovery might look a bit more like, and I think this is where the second bit is. So often that families are assuming that progress is just going to be this kind of steady upward trajectory. And I think we often find that's not the case. And it's more like you have plateaus and then things improve a bit. And I guess what's not so much on this graph is also there might be some setbacks along the way. So, a young person has a day where they do push themselves a bit too far, or they get a cold, or there's a big transition like the start of a new school term after the holidays, and we find things go backwards a little bit. But it's really trying to help them to kind of keep the faith and keep going with this approach. And again, like we said, focusing on function rather than reducing symptoms. How do we increase your function? I'm just going to say one more thing actually before I go on to resources. I think just in terms of the pacing and how young people use their energy. So there's this kind of spoons theory about if you've got so many spoons of energy that you can use for different things. So you might have 3 that you use for school and 1 that you use for kind of having a shower and looking after yourself each day, eating your meals, and 1 that you use for hobbies. And I think one of the things that can be tricky, and often how we think, I guess, about school attendance for young people, is that if they're well enough to do something like go out with friends or go to a family party or go swimming, then they're well enough to go to school. And I think some of the thing that we have to tackle sometimes is actually a young person might need a reduced timetable, but it's still important that they can do some of the enjoyable stuff as well outside of school. So that it's okay for them to be on half days and maybe have a trip out with a family at the weekend. And it's trying to get that balance, so we're using their energy to cover all areas of their life and gradually increasing school at the same time as we're trying to increase kind of enjoyable activities and hobbies and other things, rather than focusing all of their energy on trying to catch up academically. So just to point people in the kind of direction of a few resources that might be helpful. So this is a book that came out a few years ago. It's very readable. It's mainly around adults, but I think it's quite nice in terms of explaining ideas around functional neurological symptoms. So it's by a neurologist, and it's kind of talking about people she sees in her clinic and how actually in neurology clinics, a significant number of patients that present there, there's no evidence of a kind of organic underlying neurological disorder, but they have kind of significant symptoms. And again, it's a lot about how our minds and bodies can't be separated out. So that's a good book to read. And then these are some websites that I guess are specifically for different types of pain, or to different types of physical symptoms. So there's two around pain. Flipping Pain, which is around chronic pain and is more designed for adults, but it's got some really nice videos and things on it. And then Pain Bites is specifically for children and teenagers, and it talks about coping with chronic pain. It's got lots of videos. It's an Australian website with children and teenagers talk about how they cope with school or friendships and things. And then this Neurosymptoms, again, this is by a neurologist and is specifically around functional neurological disorders. So things like non-epileptic seizures. And again, it kind of gives examples of different symptoms and how people might cope. And then there's a specific website for children with non-epileptic seizures, which again is really, really helpful, I think. So I think that's everything from us. I guess just our sort of key points is that we really need to be sort of validating young people's experiences, that their symptoms are real, that we believe their symptoms, and that we are understanding the impact it's having on their life, that we're thinking about any possible underlying school stressors. So are there any things around learning needs or peer relationships or kind of social communication that might be making things more difficult for these young people in school? What reasonable adjustments can we make? Thinking about gradual return if young people aren't attending. Definitely having regular reviews about, so we have basically that, you know, I'm sure we've all been to TAC or TAF meetings, that we form that team around the child and that we all work really closely together, and sort of collaboration between the family, the wider medical system and education. So I think that's us done.